I have been asked to speak on a area which is very difficult to cover. You know, in day-to-day practice, we practice three kind of medicine. Some of us believe in evidence-based medicine. You need to have prospective randomized study to prove it, then only you believe. But in many cases, we have personal medicine. I have seen hundreds of patients, and this finding is very common. This is personal medicine, no published data. And then we have the anecdotal medicine. There are anecdotes, means reports of few cases or case series. Now this area, non-hepatic, non-neurological Wilson, falls into the latter two. Either we have evidence in the basis of, in the form of anecdotes or personal. We don't have very good case series prospective study on this area. So my talk mainly will rely on those case series. Now Srinivas has already covered this part, and there was some little bit of controversy about why liver disease comes first and then neurological and others, because this is related to our basic copper metabolism. The liver is the first organ where the copper gets deposited, and because it cannot go out through the normal track of incorporating into the ceruloplasmin and going into the bile, the copper overloads the liver. Once the liver capacity goes beyond, and then the copper comes out from the liver and gets deposited to the other organ. So it goes to the brain, so you will get the neuropsychiatric manifestation. It goes to the other organs. So I will cover these organs like kidney. It can cause the cardiac muscle problem, musculoskeletal problem, and other organs. So what are the organs which gets involved in the Wilson disease besides our liver and brain? The eye is the commonest organ. We all of us have heard about it. The cave ring is seen almost universally in all cases of neuro-Wilson. Besides that, you can get sunflower cataract and some movement disorder. Hematological problem is not uncommon, like there may be hemolysis, thrombocytopenia. Kidney is one of the common organ which is involved in Wilson disease. Mainly this renal tubular dysfunction, musculoskeleton. Neurologists, they commonly encounter this problem of musculoskeleton, which may be a presenting symptom of Wilson. Then cardiac manifestation. You can have cardiomyopathy, arrhythmias, then other organs. So let's go one by one. Before that, how common is this manifestation? I mean to say, if you go through these big studies, so-called big studies, what proportion of patients they do come to you with non-neurological, non-hepatic manifestation? Extremely uncommon. This is the South Korean study of 245 cases, mean age of 15 years. This is a pediatric study. Obviously, there is a difference between the different set of presentation between pediatric and neurology. The study from Neiman's always show the neurological Wilson is the commonest, and study from Herschel Center will show the liver disease is common. So since this is a pediatric study where you get more often liver, it is a 55%, neurological around 22%, they have pre-symptomatic 55, but the area of interest for my talk, the other, means the joint manifestation was just one in the form of arthralgia. So in the pediatric study, it is uncommon. Let's go to the other study. This is one of the largest study from the Neiman's Talley et al. 282 cases collected over 3 decades. Again, because this is neurology center, so 75% neurological, 15% Wilson's, but osteomuscular, means muscle and joint, only 2%. This is as a presentation. But if you take the osteomuscular manifestation of Wilson disease, it is not uncommon. They got a significant proportion of patients who had osteomuscular manifestation in addition to neurological. Like there is 37 patients had arthralgia, 6 patients arthritis, proximal muscle weakness 22, right? So in general, other manifestations are not very common. This is another study, was 217 patients, and again, just 2 patients, 0.9% had osteomuscular manifestation. So, but this study is from China of around 75 children, out of which 72 of them less than 18 years. They have given a rather better perspective. This is not the presenting symptom there, because lot of figure is overlapping figure. But what they have seen in their 75 cases, they have 6 patients who had hemolysis. There is a 6 patient who had hematuria or proteinuria, there is a 5 patient with amenorrhea, and they have degenerative joint disease in 3 patients. So though uncommon, but it is not extremely rare. Now coming to the osteomuscular manifestation, bones and joints involvement, it is not so uncommon. Maybe the presenting features which I have shown, around 1 to 2% cases of Wilson disease can first time come with a bone and joint problem. Unless you start investigating, then they gradually develop others, or the joint symptom may evolve after the initial neurological symptom. But asymptomatic radiological abnormalities are very common. They can have joint pain, but they can have arthritis, mainly large joint. The knee is the commonest joint, and there may be a spinal problem, and the patient can come with the non-traumatic fractures. Now let us see those series. This is one of the meta-analysis sort of thing, 15 case series, because I was telling about the anecdotal medicine. This is 7 to 42, the number of cases maximum of this 15 series. But what they have shown, the bone loss is almost 24 to 88%, osteomalacia around 1/3, and the fractures up to 1/3 of the cases. But when you are doing DEXA scan in this patient, the adult study have shown osteoporosis in 43 and pediatric cases in 67% of the cases. Now the question is that these abnormalities, are they related to the copper deposition, or they may be related to underlying liver disease? Now this pediatric study have shown, despite giving chelation therapy for 1 year, they repeated the DEXA, there is no change. So that probably hints at that it is not only the copper, it may be related to the underlying disease which this patient has presented to you, maybe the liver disease and other factors. Articular manifestation is usually mild. They usually affect the large joint, mainly the knee. And you have to remember, if there is a precocious onset of osteoarthritis, means degenerative bone disease is coming in a younger age group, then think about the Wilson, maybe the underlying cause, and there is no specific treatment available. Now, you always think that D-penicillamine is the answer for everything. Now, you start D-penicillamine, patient may develop joint problem, and that may be related to the drug-induced SLE, good posture, myasthenia, or dermatomyositis. So you have to keep it in mind. When are you handling the joint disease? Is it the before starting therapy? It is disease related. If it is after starting therapy, it may be the therapy related. And there is one case report from Ava's team. They have shown that joint disease is reversed by liver transplantation. So that indicates is maybe the copper related joint problem. In this case report, this 11-year-old boy who had a hepatic Wilson with joint manifestation, and there is a dramatic recovery to the joint symptom by day 4, and on 1.5 years follow-up there is no joint symptom at all, our liver transplantation. So when you suspect Wilson disease, like we are talking about when patient has come to mainly with the joint symptom. If there is a recurrent and unexplained joint complaint, think about the Wilson and this entity, the early osteoarthritis, especially in the large joint in a young patient. You don't expect degenerative joint disease in 20 to 30 years. Young patient coming with early osteoarthritis, please consider Wilson disease and chondrocalcinosis, which is very common after 6 decades. But if your patient is come to you with chondrocalcinosis in 20s and 30s, think about Wilson disease, you need to do investigation. What causes the joint symptom? Is it the copper which is getting deposited or something else? First hypothesis is probably it is related to the abnormal movements. Because of neurological involvement, they have recurrent microtrauma, falls, pain, dystonia, and that can give rise to post-traumatic problem. Second hypothesis, there are some evidence to say the copper gets deposited in synovial membrane and cartilage, so that can cause the joint problem. And the Abbas case report of reversal after liver transplants support that. But this is a series, pediatric series, 6 out of 6 children, 8 children presented with Osseomuscular manifestation, but on follow-up, 6 of them developed neurological. So it probably related to underlying neurological problem also. Cardiac manifestation, we don't consider cardiac manifestation as a presentation of the Wilson disease. It may not be a presentation, but there are some evidence to say the copper gets deposited in the heart, there may be cardiomyopathy, arrhythmias, there may be cardiac death and autonomic dysfunction. Now this study of 53 cases of Wilson disease, the adult study, 21 year of age, mean age, they got the ECG abnormalities almost 1/3 of the cases, 34%. They have that orthostatic hypotension, Valsalva maneuver abnormality, almost 1/3 of cases, and there are 2 cardiac deaths. One was due to ventricular fibrillation, and another was dilated cardiomyopathy. This is a 42 cases of Wilson disease from the Czech Republic. They have a control arms, and they have done Holter study, 24 hours ECG monitoring and echo, and what they have shown, there is a, compared to the control, there is a evidence of cardiomyopathy, and almost 42% had some arrhythmias. And this is the study from Niemann's on 50 patients of Wilson disease. ECG abnormality was documented in 30% of the cases, but most of them are benign arrhythmias. So regarding the cardiac part, we should probably include the cardiac evaluation as a part of Wilson disease workup, and cardiac arrhythmias and dysfunction may have some therapeutic and prognostic implications. Also, Coombs negative hemolytic anemia is seen almost 10 to 15% of the cases, and hemolytic anemia may be mild and transient, and it may be the presenting symptom. There are case reports from India say presented with hemolytic anemia, diagnosed as Wilson without liver disease, but all of us are aware of this fact that fulminant Wilson almost universally they are associated with IV hemolysis, and that is related to basically excess free copper causes the oxidative damage. Renal manifestation, copper deposition in the renal tubular epithelium has been documented. It causes renal tubular dysfunction, both proximal and distal, and as a result of which there will be a nephrocalcinosis or nephrolithiasis even. But glomerular injury is uncommon with Wilson disease. It is more common with the D-penicillamine, but there are case reports of glomerular injury as a presenting symptom of Wilson disease, and there may be a subset of patients who can have IgA nephropathy, part of the liver disease. So in this study of 85 cases of pediatric Wilson disease from China, what they have shown, renal impairment as initial symptom in 8% of the cases, and along with other manifestation, renal involvement is quite common, but on follow-up, the dependent-induced renal impairment was seen in 10%, and we had a case in the morning discussion on dependent-induced renal injury. So how do they present? They can come with mostly microscopic hematuria because of nephrocalcinosis, but nephrolithiasis may be a presentation with renal colic. So what will you investigate? That renal involvement should be looked at when you are diagnosing Wilson disease. You should, to start with, you are looking for renal tubular dysfunction. So you should look for the low molecular weight proteinuria. You have some biomarker in the urine also, and while later on therapy, you look for glomerular injury, so high molecular protein including albumin while the patient is on therapy. Regarding management, I want to emphasize one point, that renal tubular acidosis related microscopic hematuria, they may not respond to your D-penicillin therapy alone. You may be thinking that I am giving the chelator and the copper is deposited, remove, it doesn't. Basically, it is a nephrocalcinosis that needs to be corrected. So you need to correct the renal tubular acidosis, then you get the result of microscopic hematuria, but D-penicillamine induced nephrotoxicity you need to stop. I want to quote this study. There is a little bit of discussion from the ABHA's team. They have reported the deep jaundice. This is a paper they have shown the 40 patients with a deep cholestatic hepatitis when bilirubin is more than 20 for more than 6 weeks. They got a ring. What they call is bile pigment ring. And bile pigment ring, it disappears when the bilirubin comes down to 10. There is some point by which you can differentiate it, but the point here is that you need a experienced ophthalmologist to detect KF ring. This is easy to differentiate, but if the ophthalmologist is aware of this fact. So KF ring is not always synonymous with Wilson disease. It can have other cholestatic liver disease where you can get KF ring. Sunflower cataract is more of a theoretical discussion. Very rarely present. 1 or 2 cases only. Dr. Ghosha, always present with KF ring.
Dr. Podar, we might have to
finish. So to conclude, non-hepatic, non-neurological manifestations are uncommon, but often associated with hepatic and neurological vision. If you see all this series, they are not the early manifestation, they are the late manifestation. Again, going back to the copper metabolism, from the liver it goes to the other organ and then get manifested. So I want to put the 3 points about that when you should look for Wilson disease when patient is come without hepatic or neurological Wilson. First, if you get to see a young patient with premature osteoarthritis, around in the 20s or 30s, osteoarthritis, so think about Wilson disease. Unexplained IV hemolysis, especially in young adults, think about Wilson disease, even they are not having any features of liver or neurological Wilson. Unexplained hematuria or renal stone in a young patient, think about Wilson disease. These 3, you need to think about Wilson disease, and I guess all Wilson disease patients, we should do a thorough cardiac evaluation because arrhythmias are not so uncommon. Thanks for your patience here.
Thank you, Dr. Ujjal, for excellent talk. 1 or 2 questions I wrote from the floor. Till they are thinking of this, one of the manifestations, especially in pediatric age group, rickets, I think you mentioned about osteomalacia and everything, but I think Dr. Ashish is here to show so many cases, with the knock, knees and all that. That's one. And number 2, you said evaluation of the heart should be done. Now, whether this is heart involvement is because of copper per se, or this may be cardiomyopathy related to underlying cirrhosis. So, how to make out this very thing?
Regarding the rickets, yes, that may be a part of renal ricket because renal tubular acidosis is not uncommon. Around 10 to 20% cases people have reported. So there it can manifest with rickets. Cardiac involvement, people attribute it to the copper deposition in the muscle. That called the cardiomyopathy. But regarding arrhythmias, we are not sure it is related to copper deposition or not. But arrhythmias are quite common, and most of the time it is benign arrhythmias. But still, we should look at it.
Just one conclusion. There is one study which quoted that recurrent gallstones, in patients with recurrent gallstones also one need to look for
I said there is a pigment stone because of hemolysis. Recurrent bouts of hemolysis can give rise to gallstone.
That is a good point that he's raised. If you have a young patient who presents with jaundice, even with hepatitis, and she has a gallstone, then you should look for, work up the hemolytic anemia. And if there is a Coombs positive, then you can knit everything together.
Yeah. Low-grade hemolysis is well known. Yeah.
Sir, just a question to all experts. How much is the drug-induced lupus seen? I mean, it's reported with penicillamine. Is it that common or... Okay. The other thing was that some case reports of pancreatitis as a presentation in Wilson's disease. So that was what I wanted to, not with gallstones, pancreatitis in absence.
I have listed in the table, but I didn't spell it out. Unexplained pancreatitis. Yes.
No, so I think at the end of this talk, are we saying what are the additional tests we need to do to look for extrahepatic, extra neurological manifestations, and do we need to do them in all patients or unless there is a clinical suspicion? I mean, do we look for RTA in all patients of Wilson's or not? Do we do a cardiac evaluation in all patients of Wilson's or not? This is the answer we need.
Abhay, you are absolutely correct. That I started with the statement that this area we don't have evidence-based medicine. So now we have to develop consensus. But what after reviewing the literature, I can say, I think all patients we should do the renal evaluation.
We can do a urine routine and all.
Renal acidosis. No, so not renal. Only urine routine examination will not be sufficient. You should look for nephrocalcinosis part.
So what will be the basic thing you'll do for RTA?
Calcium, urine phosphate.
So in all patients, urine calcium and phosphate?
I think all patients we should look for. It is not so uncommon to have renal tubular dysfunction, and they may be asymptomatic. Once you look for it, you will get the changes. Cardiac evaluation part, people started recommending we should have at least echo and ECG to look for cardiac abnormality. Hemolysis part, obviously you don't need to do anything, and
these are the common
joint,
ones.
you
Joints
don't
are
do
obvious
anything.
clinically,
Anyway,
yeah, they
the
talk
bone
about it,
disease
yeah.
is quite common,
Yeah.
it will be manifest. So I think renal part.
Renal would be the one,
And
yeah.
cardiac.
Okay, thank you.
So this was one of the cases that I encountered as a pathologist in I'm a pathologist, sir. So I encountered a hemolytic patient with a hemolytic picture. Now, when I contacted, the case was referred from a hematologist. So when I contacted him, so we had the liver function test revealed mild elevation of bilirubin and transaminases, sir. And the girl was around 19 or 20 years old. So I told him, sir, the picture looks like a hemolytic picture, so we'll get a Coombs test done. But unfortunately, what happened, Coombs turned negative. Now, Coombs negative hemolytic anemias are not very common to detect, sir, firstly. Secondly, now the problem was that with the techniques of Coombs, the techniques are quite, in the laboratory, if you don't follow the techniques.
What is the point that you're
So the
making?
thing
Come
is,
to the point.
now,
Are you
after that when
making
we
a comment or
evaluate,
what are you
after
doing?
that we lost the patient for 15 days, then further when she came back, there was a suspicion that time of the hematologist that there was a KF ring. Then he sent it for this thing, and I isolated what I say is hemolysis, how much you encounter, sir.
No,
as
it
a
is
first.
not a common, but if
It's
you get
distinct.
to
Yeah.
see this kind of patient where this unexplained hemolysis,
Yes,
especially Coombs negative, think about Wilson disease. I am going to prime you, sensitize you that these are the manifestations known in Wilson. So if you get to see, this is not a very common manifestation. But if you get to see a case like what you have seen, you should think about Wilson disease.
So I just want to tell you that
Dr. Podar, it is the clinician who has to think, not the pathologist.
I think beside this Coombs negative,
We
we should
stopping-
not forget the G6PD deficiency also. If G6PD is deficient, you can think other way around also.
I just want to share one case of precocious puberty
Abha
in a
has been
13-year-old.
signaling,
Just one, precocious puberty in a
Last-
13-year-old. So endocrine is also there.
Yeah, endocrine, yeah.
Thank
Thank you.
Thank you so much, Dr. Ojha.